Good evening, one and all. What a fantastic evening. Today we are going to have a wonderful topic, which is, I can say, most neglected topic or most difficult topic to discuss, to apply on our patients. So, that is nothing but pulmonary hypertension. Before jumping into there, my best wishes to one and all who have joined across India on this Ganesh Nimarjan Day. This is, I believe, very humble way of conducting a academic session and then dedicating to our beloved Lord Ganesha ji. When we look at the evolution, let me recollect my very young days where I was a medical resident, medical student. 25 years back, when a case is diagnosed to have pulmonary arterial hypertension, then the chance of survival for such a patient would be hardly 1 year, 2 years. In 25 years, there's a lot much research have happened, lot much new molecules have entered into clinical studies and then approved for the same. And patients who are suffering from pulmonary hypertension are now having a fresh breath of life. So, most important is, there is always a delay in recognition. I just want to bring an analogy here. What happens when we miss a lung cancer to diagnose in stage 1, instead we diagnose in stage 4? The same analogy applies to pulmonary hypertension as well. The earlier you detect, the earlier you initiate the medications, the earlier the appropriate measures have been taken care for the given patients, they will start getting better. They will have a better quality of life. To discuss and in detail, today we have a wonderful panel across the India. So let me introduce Dr. Murali Mohan sir. If I can say, one pulmonologist across India who have mastered pulmonary hypertension management, he is the expert. So, sir, thank you for honoring us on this special day. And sir will be delivering a talk on overall view and management of pulmonary hypertension today. And sir is currently working as a senior consultant, pulmonologist, and academic director of the departments of both internal medicine and pulmonary medicine at Narayana Hrudayalaya, Bengaluru. And he was earlier professor and head of the department at B.R. Ambedkar Medical College, Bengaluru. And I'm sure in India, sir doesn't need any introduction. Thank you, sir, for honoring us. And next we have Dr. Ravi Dosi. He again, I was not kidding. We must call him, at least in CCI Pulmonology Forum, the Ravi Dosi. Okay, one and only. Okay, whenever he is here, okay, he comes with a lot of energy. And Dr. Ravi is currently working as a professor at Indore, Kokila Ben Hospital. Welcome, Dr. Ravi, and thank you for your presence here. I invite Dr. Supreet Batra, who is currently working as a HOD Pulmonology at Batra Hospital and Medical Research Center, New Delhi. Good friend of mine, a wonderful academician. Thank you, Dr. Batra. welcome Dr. Naeem Firdos, wonderful human being, good friend, currently working at Paras Hospital, Srinagar. Thank you. I'm sure, Dr. Naeem, you are the one, who have initiated CCI to take this topic, and thanks for that initiation. Last but not least, a gorgeous woman, Dr. Shilpa Jain, did DNB Pulmonary Medicine, predominantly a clinician. She is under transformation into an academician. So she is currently working with Criticare Asia Hospital, East Gurgaon, Mumbai. Thank you, Dr. Shilpa. And I must also thank each one of the core members of CCI for giving me this opportunity to moderate this session. I'm Dr. Vijay Kumar Chennamchetty, consultant intervention pulmonologist at Apollo Jubilee Hills, Hyderabad. And for the past couple of years, I'm blessed to hold the position of CCI webinar coordinator. And I sincerely thank the core team, NH Krishna Anna and Narayan Pradeepa, Ashish Dubey, Anil Maske, and all other good friends. And without wasting much time, I invite Dr. Murali sir to share his wisdom on pulmonary hypertension, and then followed by Dr. Naeem will share his couple of cases. Dr. Shilpa will share one case, followed by my dear delegates or audience, whoever may be. I request each one of you to, whatever the queries, don't think it as a silly queries. Okay, they will be useful pan-India. For the past many months, the webinar audience are, across the India, there are at least 800 to 900 logins are happening. So your question may show a significant light and wisdom on the difficult scenarios that you want to express. Please do not hesitate to ask the questions. We'll take definitely your question. Over to Murali sir. Thank you, sir.
Thank you so much to Dr. Vijay Kumar Chennamchetty for inviting me to, be part of this very, very interesting and topical discussion and being part of this great panel. I look forward to sharing what little I know. Dr. Vijay Kumar was too kind when he said expert and so on. I'm still in the process of learning. And I have the good fortune to be associated with a wonderful bunch of cardiologists and pulmonologists in my hospital, from whom I've learned so much. So my initial plan is just to give you an introduction, maybe about 10 slides. But let me not forget here, to echo what Dr. Vijay Kumar said. Greetings on this very auspicious day. It combines the last days of the Ganesh Chaturthi, the Visarjan that's happening all around us. A lot of noise, but also, as you heard from Dr. Naeem Dar, Eid Milad, Naeem Bhai, very glad to be on this wonderful day of the birth of the Prophet. So it's an auspicious day, and let's hope it brings us a lot of joy and the joy of learning. So can you all see my screen?
Yes, sir.
Okay, let me close this down. Yeah. So a lot of what I've taken is coming from the 2018, it was published in 2019, overview of the 6th World Symposium on Pulmonary Hypertension. Then in 2022, we had the ESC-ERS guidelines for the diagnosis and treatment of pulmonary hypertension. And a lot of that has been incorporated into this textbook of cardiology, Tandon's textbook of cardiology, where my former colleague, he's now gone off to Cambridge to do his fellowship in transplant at the famous Papworth Hospital, Dr. Syed Tawsheed, and I, Murali Mohan, we wrote for this chapter, we wrote the contribution on the heart and lung disease. So if you can read that, I think it summarizes a lot of what is important to us as pulmonologists. But it's also very important that we know about pulmonary arterial hypertension, because it's said that when you look at I'm sorry, this is not advancing. Okay. When you look at the pulmonary circulation, it's said that it lies between the territory of the cardiologist and the pulmonologist and is understood by neither. So let's keep some of those normal parameters in the heart in mind, the pulmonary circulation especially, before we go any further. So if you look at the pulmonary artery pressure, we look at systolic pressure, we look at diastolic pressure, and we look at mean pulmonary artery pressure. And these are very important because what is often given on an echocardiogram is the PASP, or the pulmonary artery systolic pressure. It's usually somewhere between 15 and 30 millimeters of mercury. All these values are in mmHg, except, the last one, which is a percentage, and the cardiac output, which is in liters. And I'll come back to the PVR later. So the pulmonary artery systolic pressure is around 25. The diastolic pressure is about 9. And the mean pulmonary artery pressure is 15, ranging anywhere from 9 to 19. Once it reaches 20 and above, we now have the new definition of pulmonary hypertension. So keep that figure in mind, a mean pulmonary artery pressure of 20. The pulmonary artery wedge pressure is what happens when you take a pulmonary artery catheter, a Swan-Ganz catheter, for example, float it into the right ventricle, into the pulmonary artery, and advance it as far as it will go until it wedges in the smallest arterioles. Now, it is reflecting the left heart pressure or the left atrial pressure. So the pulmonary artery wedge pressure is about 9, ranging from 4 to 12. And this is again a very important number to remember, because what is called post-capillary pulmonary hypertension and pre-capillary pulmonary hypertension are divided into two groups based on the pulmonary artery wedge pressure. And we'll come back to this. The cardiac output is an important parameter to remember, because it tells you how many liters per minute is being pumped out of the heart. When it's divided by the body surface area, it becomes the cardiac index. And it varies anywhere from 4 to 8, usually around 5. So we all remember that our vital capacity is about 5 liters. And the match between the cardiac output and the vital capacity, or the tidal volume per minute, is around the same. The pulmonary vascular resistance, measured in Dyne centimeter to the raised power of 5, Dyne second centimeter raised to the power of -5, is about 70 and varies from 20 to 130. But for convenience, we usually use something called Wood units. And as you can see in the bottom right, 1 Wood unit is into 80, gives you the pulmonary vascular resistance in Dynes. But we usually talk in terms of Wood units. And you'll see the same being used in the definition of pulmonary hypertension. Don't worry about the last two. We'll come back to those later if necessary. So the latest definition of pulmonary hypertension, this is very similar to what the 6th World Symposium defined it as. Pulmonary hypertension is divided as a mean pulmonary artery pressure greater than 20 millimeters of mercury at rest. When you call it pre-capillary pulmonary hypertension, you look at what is called the pulmonary artery wedge pressure, which, as I told you, reflects the left heart pressures, basically the left atrial pressure. It has to be less than 15, because if it is greater than 15, it means the pulmonary hypertension is occurring secondary to left heart disease. So this is called isolated post-capillary pulmonary hypertension, when the pulmonary artery wedge pressure is greater than 15, and it's called pre-capillary pulmonary hypertension when the pulmonary artery wedge pressure is 15 or less. In both, remember, the mean pulmonary artery pressure is more than 20 millimeters of mercury. But then you have some conditions where you can have both pre and post-capillary pulmonary hypertension. We call that combined pre and post-capillary pulmonary hypertension, where the mean pulmonary artery pressure is greater than 20. So there is pulmonary hypertension. The pulmonary artery wedge pressure is greater than 15 millimeters of mercury, saying that there is a great contribution coming from the left heart. So the back pressure is very high. But there is one more figure we've not talked about, and that's the pulmonary vascular resistance. If it is greater than 2 Wood units, that also defines pulmonary hypertension, but it defines pre-capillary pulmonary hypertension, because what the pulmonary vascular resistance greater than 2 Wood units tells you is that the resistance in the arteries and arterioles of the pulmonary circulation is high. So the problem is not in the pulmonary veins or the pulmonary venules, but it is before them. So it is a pre-capillary pulmonary hypertension. But you will come across the occasional patient, in fact, not that uncommon. We see quite often in our practice. The mean pulmonary artery pressure is greater than 20, so there's pulmonary hypertension. The pulmonary artery wedge pressure is greater than 15. So that tells you that there is a left heart contribution to the pulmonary hypertension. But also the pulmonary vascular resistance is greater than 2 Wood units. So there is also a contribution from the pulmonary capillaries and pulmonary arterioles, telling you that there is an element of pre-capillary pulmonary hypertension. So we're talking about combined pre and post-capillary pulmonary hypertension. We don't use exercise pulmonary hypertension by and large, but they talk about picking it up when you're doing a exercise test and you can find out what the mean pulmonary artery pressure to the CO slope is. Let's not worry about it. So most often we use only the pulmonary pressures measured at rest. And those are the important definitions of pulmonary hypertension to remember. If you look at the classification of pulmonary hypertension, there are 5 groups. It looks very busy, but essentially group 1 is where the pathology, and I think we'll come to this later in the question answer session. Group 1 is where the pathology is in the pulmonary arterioles themselves and in the pulmonary capillaries. Here, very often it is idiopathic or genetic and can be associated with a variety of other conditions. So as pulmonologists, we'll come across idiopathic pulmonary hypertension, and mostly we'll come across connective tissue disorder associated PH and HIV infection. We might sometimes be seeing patients with congenital heart disease, and we also will be called in by our gastrohepatology colleagues in cases of portopulmonary hypertension. Let's not worry about the others, but this small group, pulmonary vascular involvement due to venous or capillary involvement, defined as pulmonary veno-occlusive disease or pulmonary capillary hemangiomatous. I've seen about 5 cases, but it's an important thing to remember because this group, you use pulmonary vasoactive drugs, causes a significant worsening. I'll come back to this, but our group is group 3 or hypoxia or lung disease, associated with obstructive lung diseases, restrictive lung diseases, mixed obstructive restrictive disease, where there is hypoxia without lung disease, and of course, developmental lung disorders. And there's a big group which we'll be talking about later due to pulmonary artery obstruction, especially CTEP. But if I have to summarize this into 5 main groups, pulmonary arterial hypertension, the only one which should be called PAH, all the others are called just PH. This is where, as I told you, the problem is in the arterioles and capillaries. Then there's pulmonary hypertension associated with left heart disease, such as left to right shunts, diastolic dysfunction, systolic dysfunction, and so on. All the problems start with the left heart. Our group, the patients we see who present with pulmonary hypertension, present with hypoxia or lung disease. And group 4 is PH due to pulmonary artery obstructions, typically clots, but it can also be due to obstruction due to tumor emboli or due to tumor growing pulmonary angiosarcoma. Again, I've seen about 5 cases of those only. So rare, but important not to miss. And finally, there will be miscellaneous causes or multiple mechanisms operating, and that falls into group 5, where it does not fit neatly into one of the other 4 groups. So what should you do when you have somebody with pulmonary hypertension is always assess their functional class, very similar to the NYHA classes that we learned in 3rd MBBS. That's important because survival is, very closely correlated with functional class. Those who are in functional class 2, that means they have very slight limitation of activity, have a very good survival, whereas those who have severe limitation of activity, basically symptoms at rest and overt right heart failure, have a very poor survival. Dr. Vijay Kumar already told you that their survival is somewhere between 2 and 3 years. About 2.8 years is what is usually given. Similar figures that used to be told when we got a patient with IPF, but as we see, both conditions are showing a fantastic improvement. What we often use when we look after patients is the 6-minute walk distance. And this correlates very well with functional class. And as the functional class gets worse, obviously the 6-minute walk distance comes down and also is associated with mortality. So most studies have used 6-minute walk distance as a surrogate marker for mortality. What we use mostly is echocardiogram to make the initial diagnosis of pulmonary hypertension, but it's not often very accurate. And I'll at this point take you through how we make an echo diagnosis of pulmonary hypertension and why it must always be covered with right heart catheterization as far as possible, at least for group 1 and group 2 PH. So what we do is we have a clinical suspicion of PH, and we'll take that up in the question answer session, I'm sure. And the first thing you look at is the echo assessment of the TR jet velocity. Okay, and I will come back to this when we come back, I'll show you. But basically what you do is you take the TR jet on an M mode, measure its velocity. If it is more than 3.4, pH is very likely. So if you need to, you can confirm by right heart cath, but there's a very strong likelihood that the person has pulmonary hypertension. If the TR jet velocity is less than 2.9, pH is very unlikely. So it's ideal to search for an alternative diagnosis to explain the suspicion that you had of pH. Now, if it is between 2.9 and 3.4, then we need to confirm it with other echo features. So if these other echo features are present, there is a very strong likelihood of pulmonary hypertension. If these other echo features are not present, then probably you will have to look for another condition. So what do you look at? You look at on the echo, and in fact, you can also see it on the CT pulmonary angiogram, the RV ratio to the LV diastole or diameter or area is greater than 1. That means the RV is more, LV is less. If you look at the interventricular septum, it is straightened. So it gives you a D sign. So the interventricular septum is straightened out instead of going towards the right ventricle. So the whole thing looks like a D, and that's a very good sign. And again, you have to look at the contractility of the ventricle, the right ventricle, and something we call the TAPSE, the tricuspid annular plane systolic excursion. If it is more than 17, probably the right ventricular function is normal. And this ratio of the TAPSE to the pulmonary artery systolic pressure is important, because if the right ventricle is pumping less effectively, it cannot generate a very high pulmonary pressure. So the TAPSE to PASP ratio will be less than 0.55. If it is more than 0.55, then it's, very useful to depend on the pulmonary hypertension. The next thing we look at is the pulmonary artery. Don't worry too much about these figures, but one of the key things is to look at the ratio of the diameter of the main pulmonary artery to the aorta. If it's greater than 1, and you'll see a very similar thing on the CT scans, the CT pulmonary angiogram. If the aorta, it looks smaller than the main pulmonary artery, then you're probably dealing with pulmonary hypertension. And again, if you measure the diameter of the pulmonary artery, it should be more than 25 millimeters of mercury. Another very important thing that the ICU people also look at and the ER people look at is something we should also look at. Look at the dia is greater than 21 millimeters of mercury, 21 millimeters, then you're saying that the back pressure into the IVC, the inferior vena cava, is very high. So what happens is that tells you that the RA pressure is very high. Then you look at how it's varying. You make the person sniff. If the variation is less than 50% and moves less than 20% with tidal breathing, that again indicates that the RA pressures are very high. And finally, you look at the RA area, that's the right atrial area. Look at it in end systole, and if it is greater than 18 centimeters square, again, a very good evidence of pulmonary hypertension. So don't be satisfied with just what the echo technician gives you. Look at these figures yourself. Look at what is the TR jet velocity, and I'll show you how to calculate the pressures from the jet velocity. Measure it yourself, and if it is somewhere between 2.9 and 3.4, then you look at all these features. So let's not worry about these. So I'll come back to the measurement. So basically, when you have the pulmonary artery, TR jet velocity, call it V, 4V squared will give you the RV systolic pressure. So keep that number in mind. RV systolic pressure equals 4V squared, where V is the TR jet velocity, maximal jet velocity. Now, the RVSP has to be added to the right atrial pressure. How do you make out the right atrial pressure? You make an assumption. If the IVC is completely normal, that means the caliber is normal and it's showing you good variability with respiration, you use it as 10. If the caliber is very small, that means the IVC looks partially collapsed. It means that the person is probably dehydrated, and you use the RA pressure as low, take it as 5. If on the other hand, the IVC is very dilated and hardly moves with respiration, less than 20% with tidal breathing and less than 50% with sniffing, then you say the RA pressure is very high, and therefore you use a RA pressure assumption of 15 mmHg. You add the RVSP and the RA pressure, that gives you the pulmonary artery systolic pressure. Now, to calculate the mean pulmonary artery pressure, there are many methods. The one that is easiest to use is 0.61 into pulmonary artery systolic pressure within brackets plus 2 mmHg. So that will give you the mean pulmonary artery pressure. And the magic number there is 20 millimeters of mercury. Anything more than MPAP of 20 is pulmonary hypertension. So when at this point, I'd like to stop with a few key learning points. Consider if a patient has PH when you're treating a patient with breathlessness and fatigue, especially if the breathlessness and fatigue are disproportionate to the lung function problems that the person has. So you measure the lung function, but the breathlessness and fatigue seem much more, hypoxia seems much more. Consider if they have pulmonary hypertension. Next, always identify the etiology, put the patient to one of those 5 groups. Assess the functional status and check the 6-minute walk distance and confirm it by echocardiography. Dr. Vijay Kumar, just a couple of slides more. No, I think I'll stop at this point, stop sharing, and we'll go to the cases that our colleagues have.
So that was a very lucid way of explaining, sir. Thank you for going to very basics and explaining us the concepts of pulmonary hypertension. So may I request Dr. Shilpa to share her slides and then present the case. Over to you, Dr. Shilpa. Yourself.
Sorry. Thank you, Dr. Murali, sir. That was great. Your presence is only so effective, and your talk was so much of additional knowledge to us, actually, because pH is a very difficult topic, and to treat it is more difficult. So it was really, I'm very thankful for the entire introduction to the pH thing. So I had this case. He's a 65 years old male with a known case of interstitial lung disease. He was diagnosed around 5 years back. He presented, and he used to always stay stable in terms of his cough and breathlessness, and had a lost follow-up. But eventually he came after some months, and he came with a worsening of his breathlessness. It was a worsening of dyspnea. It was a MRC grade 3. It was almost noticed since a month. And along with that, he had mild lower limb swelling since about 15 to 20 days. He was a non-diabetic, non-hypertensive, no history of any heart disease, a non-smoker, more of a desk job fellow who used to be going to his regular office. No exposure to any kind of, because this patient predominantly stayed in Kerala, so he was in a good environment. And all this while, when he was diagnosed, since then till the day when he presented with dyspnea, he was on regular medication. He was on oxygenation of 1 to 2 liters per minute, a steroid therapy, and a bronchodilator. When initially I had made the diagnosis, the patient had a very normal 2D echo with no pulmonary artery hypertension. When he came this time, can you please change the slide? When he came this time, his oxygen level, despite of taking 1 to 2 liters of oxygen, it was around 80% on room air and 95% on 2 liters of O2. His JVP was mildly raised. He had bilateral pedal edema, and on examination, his creps, there was profuse amount of creps. So we investigated him. His chest X-ray, which he had initially presented 5 years back, was of more of an NSIP pattern on CT scan. But this time when we got an X-ray done, it showed a reticulonodal pattern on both the lower lobes. And CT scan showed extensive reticular opacities, interlobular septal thickening, honeycombing in bilateral lung parenchyma, predominantly in the lower lobe with a subpleural distribution. He initially had not taken up regular CT scans. I had said there's a lost follow-up, but this time he had a significant UIP-like pattern on the CT scan. When we investigated him further with a PFT and DLCO, he was showing a moderate restriction no small airway obstruction was there, and there was no reversibility, and the DLC was also reduced. His FEV1 was 53% of the predicted. FEV1 to FVC was 83.8. His residual volume was increased and DLCO was reduced. 2D echo has shown a left ventricular ejection fraction of 60% and a pulmonary artery pressure of 60 mm of Hg. Probably all this while he must be having a mild breathlessness, but he had never come back. So we couldn't really during that time do a 2D echo. So in such a case, just mere keeping the patient on oxygen therapy and not knowing the follow-up of how to go about with the 2D echo in such patients, is it that despite of oxygenation maintaining around 95% on 2 liters of O2, pulmonary artery pressures keep on going up? Is this the right time to introduce a drug after seeing the echocardiography? Or should we do some more tests along with it to determine a more specific pulmonary artery pressures for these patients? And do giving all the possible therapies in an ILD patient in the form of oxygen, in the form of bronchodilators, in the form of giving vasodilators, the pulmonary artery pressures come back to normal, is what we wanted to know.
Thank you, Dr. Shilpa, for a wonderful case. I presume the diagnosis, though there is no HRCT that has been provided, but I presume it has a idiopathic pulmonary fibrosis.
Yes, sir.
Yeah. And we'll discuss. Let Dr. Naeem also complete his case presentation. We'll discuss this case. Over to Dr. Naeem. Thank you, Dr. Naeem, for having with us on a Eid day. Thank you so much.
Good evening, all of you. It's a pleasure that I have been given a chance today to speak to an august senior faculty like Murali Manohar sir and Ravi Dosi sir and Vijay Kumar sir and my colleague Shilpa, as we are joining first time this CCI platform, starting with the case presentation. So let me be yes. I cannot.
Above that, enable editing. Yeah, just above. Take it another centimeter above. Just click on that, enable editing.
It's not
the
clicking.
The cursor.
Yeah.
It's not going above. So why don't you come down to slideshow?
Okay, sir. Is it fine?
Yeah.
Yeah. Yes. So this was a 60-year-old male who is a known case of COPD for last 5 years. He is a reformed smoker who has stopped smoking for last 3 years back. And he was regularly visiting my clinic. And what I was featuring in him was his exertional dyspnea, which was gradually going on increasing. He started with MMRC grade 2, then he came near about MMRC grade 3 and grade 4. And what usually he used to complain that I'm not getting relief from bronchodilator therapy, which was given in the form of triple therapy. I was using LABA-LAMA ICS. And gradually I started noting his lower extremities, especially the ankle and the sacral region. There was edema, which I noted. And no history of hypertension, diabetes in this patient. The only thing which he was going through for his COPD management as a triple therapy, LABA-LAMA ICS. Initially, this patient was on LABA ICS, but once the triple therapy came into being, I switched him over to triple therapy, there was some relief in his respiratory symptoms, breathing difficulty, but somehow he was not feeling comfortable. And all he used to say that there is some chest discomfort, heaviness, especially on exertion. These were his words. And what I used to find on his examination, his initial room air saturation used to be around 90, 91, and here I am presenting it as 93 on room air saturation. Heart rate was 96, respiratory rate was 18, and JV, jugular venous, these were dilated, and it was a raised pedal edema, as I said, was there associated with the sacral edema also. And on chest auscultation, there were decreased air entry in the basilar area. Basilar, I couldn't auscultate for any V's was not there. And the investigations which I am briefly presenting here, the chest X-ray showed CP blunting with a prominent pulmonary artery right descending branch. And in ECG, I had his ECG, but I was not able to upload it here. Was an incomplete RBB with a prominent P wave, as we see in the P pulmonale. And his last spirometry, which was with me as a record, his FEV1 was 70% of the predicted, FVC was 82% of the predicted, the ratio was 0.68, which is near normal. And what I noted in him was the reduced DLCO. This actually worried me, which I was not expecting in a COPD patient. So DLCO clinched me to go for CT first, and then I went for an echo. And these are the echo findings which I am sharing with you. Left ventricular ejection fraction of 60 with a moderate TR, with the RVSP of 60 plus right arterial pressure. As Sir said, TAPC was 16 and IVC 2 centimeter with no significant respiratory variation. The echo, I requested the cardiologist. I went to the cardiologist myself and I told him that I have two concerns in this patient. One was his complaint about the chest discomfort, heaviness on the exertion. He was not somewhat relieved by my bronchodilator therapy, which I used for his COPD. The second thing was his spirometry is showing me a reduced DLCO, whereas I can see a FEV1 by FVC ratio of a near normal 0.68, near to 70. So can you please help me with an echo? So these were the echo findings, and he rightly told me that, doctor, yes, RVSP is 60 plus RAP, so it's a pulmonary hypertension case which is secondary either to your COPD. And the CT, I remember the CT of this patient, I have not included it here. His pulmonary artery and ratio to the aorta was 1:3. 1:3, with no significant emphysemetic changes, which I expected to explain me the COPD part. So here I would like to conclude my presentation with few questions to the experts. What is the likely cause of the patient's symptoms? How will you interpret the patient investigations in light of his PFT, ECG showing P pulmonale and with the echo findings? And how, when this type of echo report comes onto the table of a newcomer, how should he go from this point? And how to manage and when to refer to a proper pulmonary hypertension clinic? Thank you very much.
Fantastic case, Dr. Naeem. If I may understand, so if I summarize, this is a 60-year-old COPD chop
Yes,
with
sir.
shortness of breath. Can you please stop sharing your screen?
Sure,
So,
sir.
shortness of breath and exertion, which is now currently to almost grade 3 to grade 4 MMRC. And on pulmonary function test, spirometry, there is mild obstructive airway defect, whereas on DLCO is too much compromise. Room air saturations were borderline, maybe I can call 91, 93 kind of thing. And with that background, echo on requesting echo, Dr. Naeem has made a wonderful point. It is the common practice when we ask a patient echo of our pulmonary patients. Okay, generally we find there is no comments on right heart issues. So it is initially when we are establishing in our practice, it is very, very important, as Dr. Naeem discussed the case with the cardiologist directly, and he went across, he stretched his limits and then went across to echo room and then sat with the patient, sat with the cardiologist and got the absolute reports there, and which revealed a RVSP of 60. So now I request Dr. Ravi Dosi, what is the likely cause of symptoms here, Dr. Ravi, and then how do you interpret the pulmonary functions, and also the spirometry is revealing only mild obstructive airway defect?
Well, definitely, sir, both the cases, they are suggesting a disproportionate symptomatology as compared to the reports which are there at hand. So definitely, apart from the respiratory problems that our patients are having, there seems to be an added element of some pulmonary artery or right heart pressure in both these cases, sir. So therefore, I would like to look at the severity of the pH and the other parameters in the echo, and then see if we can optimize lung function more on the basis of the available spirometry data and CT. And if that is not feasible, then I would like to go ahead and start treating this pulmonary hypertension.
So, Dr. Murali sir, what do you want to add here? And then do you ask any other parameters to in the echo report, or these parameters which Dr. Naeem and Dr. Shilpa has presented is good enough?
So, two or three things. Obviously, you want to collect as much information as possible and not base it on a single parameter. And whenever you look at any investigation, I mean, all of you are aware, but for the purposes of clarifying, let me take you through it. Any test, before you interpret, you look at the pre-test probability. So in both the cases that were presented, the pre-test probability of having pulmonary hypertension was very high on clinical grounds. These patients had disproportionate breathlessness, disproportionate hypoxia, developed signs of right heart failure. And if you look at their lung functions, all of them were pretty good. Dr. Naeem pointed out very clearly that the ratio, FEV1 to FVC ratio, was not bad. The FVC, if I remember right, was more than 70%. That's usually one of the 60%. So that's one of the cutoffs we use, and I'll try to come back to that later at some point. In a patient with lung disease, how do you look for disproportionate pulmonary hypertension? Because as we all know, and I think Dr. Chatterjee has already asked this, you have a person who is hypoxic, it will produce pulmonary hypertension. That is the group 3. But there is this group who will have out of proportion pulmonary hypertension. It's very, very important to remember that when you have pulmonary hypertension in a patient with lung disease, and it's only due to lung disease, they usually have only mild to moderate pulmonary hypertension. It almost never is severe pulmonary hypertension. When it is severe pulmonary hypertension, keep the possibility that is an overlap with a group 1 pulmonary hypertension. So that's the first thing to remember. So base it on pretest probability, then you do your echo. And Dr. Naeem, hats off to you that you went in and sat down with the cardiologist, because very often the echo technician doesn't even look at the right side of the heart. It took us about 6 years at Narayana to persuade our echo technicians to really look at the right side. Now it's routinely reported. But whenever any new batch comes along, we always have to, be careful that they are looking at the right side properly. And of course, one of the problems you'll face is that patients with COPD have very poor lung windows. So very often, even the echo technician, despite their efforts, can't make it out very clearly. So then you fall back on the other things that I mentioned. So look at the measured pulmonary artery pressure. Please always look at the TAPSE. As I mentioned earlier, the TAPSE tells you how your right ventricle is functioning. And if possible, look at the ratio of the TAPSE to the pulmonary artery systolic pressure and what its ratio is. Okay. Then you look at the RA size. So all these combined will tell you, yes, there is pulmonary hypertension. But don't stop there. When the patient comes to you, very often they come to you with the CT. So if you look at the CT, don't just look at the lungs. Please look at the heart. Very importantly, look at 2 or 3 things. First, look at what you already mentioned, the ratio of the main pulmonary artery to the aorta. That's a very important thing. The second thing to look at is measure the left atrial diameter, because a lot of patients with with lung disease have associated heart disease. A patient with COPD very often has associated heart disease. You know, if you recall the TORCH trial, 27% of patients died of cardiac causes rather than respiratory causes. This is a famous COPD trial. So almost more than 1/4 died of cardiac causes rather than respiratory causes. So what you need to do is say, does this person have associated heart disease? Because COPD and coronary artery disease are 2 of the commonest killers, and they often occur together because a lot of these people are smokers. So what you do is look at the LA diameter. So even on the echocardiogram, please look at the LA diameter. And on your CT, measure the LA diameter. The normal LA dia is less than 39 millimeters of mercury. Once it reaches 3940, you're already thinking of diastolic dysfunction, which has caused the left heart failure, and that pushes it into group 2 pulmonary hypertension rather than just group 3. So you may have group 1, you may have group 2, and you may have group 3, all in patients with lung disease, what you think of as group 3 PH. So look at the ECG. If you have classic features, look also at the left atrial size. So the ECG is not a very good way of looking at it, but you might find unexpectedly this person has had a silent myocardial infarction. Look at the echocardiogram, look at the CT scan, measure all these. If you still have doubts, speak to your echocardiogram colleagues, or speak to your ICU colleagues and ask them to do an ultrasound of the chest and see if there are a lot of B lines, which will push you towards a left heart diagnosis. Okay, so that is basically what I would look at as the initial set of tests when you evaluate a person with possible pulmonary hypertension.
So, to summarize what Dr. Murali sir has said very clearly, see, it is very, very difficult to establish some new practices in the centers. So, we have to make our echo technicians and our cardiologists, request them, sometimes beg them to report right heart findings as well, and then make it a habit. The moment, I totally agree with sir, now if a echo request occurs from Dr. Vijay Kumar in Apollo Hospital, definitely they will report right heart issues. So like that, you have to make our system habituated to report a very good right heart details in our echo. And it is very, very important to look comprehensively, not only depend on echo, we should also look at other investigations like CT to look for other overlap issues like left heart issues and pulmonary artery diameters. All these things we should know, we should look into it so that we can derive the reasonable conclusion, at least clinico-radiological and investigation conclusion. So now may I request Dr. Supreet. So, sir, can you please tell me anything else that you want to add here?
No, definitely, sir.
One interesting question Dr. Shilpa has ended with: do we think this pulmonary artery systolic pressure, or RVSP, which is elevated to a level of severe pulmonary hypertension, can be reverted back to normal? Your comments.
Yeah, because we all know patient with respiratory diseases during acute exacerbation, there is hypoxia, and there is an increase in the pressures, which may turn normal after an acute exacerbation. So in those cases, we should be very careful in measuring the pressures. And we all know in the patient with respiratory patient, COPD patient, it's very difficult to measure TR jet velocity sometimes. So we have to see comprehensively patients. Sometimes we may overestimate pulmonary artery, mean pulmonary artery pressures. So in that cases, we have to see comprehensively, like we have to assess not only the clinical parameters, we have to see biochemical parameters like anti-pro BNP, BNPs. We have to also see the echo findings like RA enlarged, RARB, RARB ratio, RVLV ratio, and also combining with the contrast CT to see the pulmonary artery diameter and the RA and LV ratio. So all this taken comprehensively only we should combine, try to understand that patient has got a pulmonary hypertension. Then regarding pulmonary hypertension, it is usually non-severe in patient with lung diseases, 70%. Only 5 to 10% have severe pulmonary hypertension. So, and they do not require even right heart catheterization. So basically you have to see a patient comprehensively and do not rely only on echo parameters of TR jet velocity, and you have to see comprehend. That is what is taking biochemical parameters, BNP, anti-pro BNP, and all the things, whether along with the symptoms and ABG and a PFT with the DLCO.
Thank you, Dr. Supreet. Sir, I request you to throw some light on how far in your clinical experience and then evidence says how far these elevated right ventricular systolic pressure, pulmonary hypertension, can at least to reversible to some extent. This is a $1 million question. Over to Murali, sir.
So I think what is important is to realize that if you catch any form of pulmonary hypertension early, then it can be reversible. If you catch it very late, it doesn't reverse. So the trick is to catch it early. And how do you catch it early? You always have a very high index of suspicion. So in anybody who is hypoxic, ask yourself, has this person developed pulmonary hypertension? Especially as we mentioned earlier, if it is disproportionate. Now, if you catch a person early, and we know in lung disease from all the MRC trial, the NOT trial, and so on, that if you start oxygen early, the outcomes are much better. Why are the outcomes better? Most probably because of the retardation in the progression of pulmonary hypertension to cor pulmonale, because that's the thing that is the only thing we can change. We know we cannot reverse lung disease very much in COPD. So what we can reverse is, we can reverse the pulmonary hypertension. And if you look at what is happening to the pulmonary capillaries, hypoxia is the main driver, but there are other things. There is what is called hypoxia-induced factor. There is platelet-derived growth factor, all of which do several things. There is endothelial dysfunction. There is decreased secretion from the endothelium of endothelin, but also there's reduced secretion of nitric oxide. So these are some of the important things that come out from the endothelium. Also, when you have hypoxia, there is initially dynamic vasoconstriction, and later this becomes fixed constriction or fixed obstruction. And you also get, because of the failure to secrete endothelin and NO, you'll get vasoproliferation. So the smooth muscle proliferates, the endothelium proliferates, though it is dysfunctional, and causes severe narrowing of the vascular bed. Once it reaches that stage, there's very little you can do to reverse it. So basically, start early, keep the person on oxygen, treat the primary problem, and very importantly, ensure that they take the oxygen for more than 16 hours a day, which is something patients find it very difficult to do. So Dr. Shilpa, you mentioned that your patient is very compliant with the oxygen. The trick is, the problem is, how many hours a day does he take it? And anything less than 16 hours, in fact, if you look at one of the original trials, it said 18 hours, is very difficult to ensure for most patients.
Very difficult. But sir, you said that early diagnosis. So in such patients, would he had been a regular follow-up, what do you recommend? How often should we do a 2D echo? Every year, 6 months, 2 years,
So
or
it's
just
a nice
symptomatic base?
All three, I think, are fine. But if you find that the patient is getting symptomatic faster, then I would do it, more frequently. Say maybe once in 3 months, every visit. Remember, it's some simple, non-invasive, reproducible test. Ideally, you get the same person to do it every time, which is not easy in a corporate hospital or a large hospital. Government hospital is virtually impossible to get, the same person to do it every time. The second thing is, of course, if the patient is otherwise stable, not hypoxic, you can do it once a year. Why do it more often? It's expensive and time consuming.
Thank you, Dr. Shilpa, for bringing out a very valid point here. Now, I would like to take the question of Dr. Zakir Hussain, my good friend and junior colleague from Hyderabad. How to differentiate between acute or chronic PAH, especially in morbid obese with obstructive sleep apnea and hypopnea background with high probability of pulmonary embolism. Oh, many cardiologists in echo can't say 100% if it's acute or chronic. Over to Ravi bhai.
Well, this is actually a very interesting question. And I think if I'm not wrong, then a thing called TEE would be more useful in this because very difficult for transthoracic echo also to pick up that right heart usually. So in obese patients, sometimes we even do transesophageal echocardiogram to look at that particular right heart pressure. Now, coming to differentiating between acute and chronic, I think by our routine echo, it will be a bit difficult. Maybe if we have some features suggesting acute worsening of the respiratory status. In an ABG, we have sudden acute respiratory acidosis building up. In added to the echo, then only I think we'll be able to comment on that.
Sir, Murali sir, your comment, sir.
So when you look at a patient, I assume this question is largely to do with the pulmonary hypertension, because you're talking about acute pulmonary hypertension. You're usually talking...
also, sir, morbid obese. Because here I would like to add one important point. When a patient is morbidly obese, definitely the transthoracic echo is become difficult task. To facilitate it a better window, what we do is we place the patient into left lateral position so that the heart comes close to the chest wall so that we have a better window. Or sometimes what we also do is subcostal view. That also many times it is very difficult if the patient is morbidly obese, but only expertise and experience matters. Over to sir.
Expertise, experience, and being very patient and looking very carefully for where you get the best window. Very often that is, needed.
Yes,
so I know the question was basically how do you differentiate between acute and chronic?
Yes,
and a good clinical, background was given. So I think when you're talking about acute, you're typically talking about acute pulmonary embolism, and you want to differentiate it from all the other conditions which will lead to a slow and chronic rise in pulmonary pressures. So that is the basic thing. Now, when you have an acute PE, the pulmonary arteries do not dilate that much. So if you look at the pulmonary arteries, they don't dilate that much. Your RA-RV may dilate, but the pulmonary arteries cannot dilate very much. Two, the pulmonary pressures don't rise very much because the right ventricle does not have the capacity to adapt suddenly. Unlike the left ventricle, which can adapt reasonably well to afterload, when the afterload is on the right ventricle, it doesn't adapt very quickly. So in fact, it goes into gross failure, which is why the person goes into cardiogenic shock. Whereas if you have a slow rise in the pressure, the RV dilates, but at the same time hypertrophies, the RA dilates, and the pulmonary artery pressures are found to be high. So if you find the PA pressure is very high, the PA is dilated, the RA is dilated, but the RV is hypertrophied, you're probably dealing with chronic. Now, is it acute on chronic? That is very difficult to say on an echocardiogram. So what you have to do is you have to do a CT scan. And there are some things that we can talk about when we come to CTEF, how to differentiate acute on chronic. What you'll find is that almost 20% of patients with so-called chronic thromboembolic disease, with acute pulmonary embolism already have chronic pulmonary thromboembolic disease. And that's a realization that has come out in the last 5 years or so. Even today, we discussed in our CTEF meeting that at least 2 of those patients are acute on chronic disease.
Yeah, we will discuss Dr. Jayaraman's question and Dr. Tridip's question soon. And meanwhile, I would like to ask our Dr. Ravi, what is the overall pathogenesis? Can you please simplify? And then please emphasis on molecular abnormalities and genetics in PH.
Well, sir, the different pathogenic mechanisms of pulmonary hypertension, we can divide into some 6 types. Most commonly, which we come across in lung diseases, are those which are of the venoconstrictive type. where because of hypoxia in conditions like COPD or in high altitude, we see pulmonary venoconstriction and we have pulmonary hypertension. The other common other pathogenic mechanisms are passive mechanism, which cause pulmonary venous hypertension when the primary reason is a left heart issue like a mitral valve or a left atrial myxoma. Then we have hyperkinetic conditions like left to right shunts, which can happen. We have obliterative conditions like pulmonary thromboembolism. We have obliterative conditions like schistosomiasis or interstitial lung disease. And we have a big group of diseases, big group of pulmonary hypertension, which come in the idiopathic variety, where we actually don't know which is the reason. Commonly seen examples are primary pulmonary hypertension, HIV cases. In them, we actually don't know what is the actual cause of that pulmonary hypertension. Now, as far as the genetic factors are concerned, the most identifiable association is that with the bone morphogenetic receptor, the BMPR2, which is basically a TGF beta receptor family. Almost 70% association, a very strong genetic susceptibility is seen with this BMPR2 mutation. And the BMPR2 helps in vascular development and maintenance. So it regulates the growth and maturity of the endothelial cells. Nearly 70% heritable 70% heritable BMPRT mutations are seen, and 20% are inheritable. So this is the most identified one. Apart from this, there are some other there are some other mediators which help and coordinate in this pulmonary hypertension mechanism, like vasodilators like nitric oxide, prostacyclins, and vasoactive intestinal peptide. If they are decreased, it leads to more of vasoconstriction and pulmonary hypertension. And there is an increase sometimes of vasoconstrictive mediators like thromboxane, serotonin, and endothelin 1. So this is what broadly happens. But basically, the four final things which lead to pulmonary hypertension, which because of all of this are sustained vasoconstriction of the vasculature, vascular remodeling, some in situ thrombosis happening, and arterial wall stiffness developing. If all of these result from several different mechanisms, it results in pulmonary hypertension.
Thank you, Ravi Bhai. So may I ask Dr. Naeem, can you please throw some light on what is the role of serotonin in the pathogenesis of pulmonary hypertension?
Hi, sir. Regarding serotonin, how it came into the existence as a factor that leads to pulmonary hypertension, or what we call as serotonin hypothesis in pulmonary hypertension, was the dietary pills which we were using, aminorex, phenethylamine. So what was observed that serotonin can activate pulmonary artery fibroblasts and promote adventitial fibrosis through a signaling, as Ravi sir said, TGF beta 1 pathway. And there is one more class of pulmonary artery smooth muscle cells, PASMC, through a NADPH oxidase pathway. So these two pathways, TGF beta 1 and NOx 1 pathway, are one of the main reasons which are found which have a role in the pathogenesis of PH due to serotonin release. And it has also been found that there is a promise of serotonin synthetase inhibitors, which is still undergoing trial, that it is helping us in evaluation of this pulmonary PH by using these inhibitors.
Thank you, Dr. Naeem. So, my dear friends, when an obese patient comes to you, when we are considering to add any drugs to modify obesity, to facilitate weight loss, particularly these fenfluramine kind of medications, please be aware that you may end up in a side effect of pulmonary hypertension because of usage of fenfluramine. So with this, Now I request, sir, it is the question is to Dr. Shilpa and Dr. Murali, sir. First, I would like to request Dr. Shilpa to throw some light on what's your experience in right heart catheterization. I know across India, many labs, okay, they don't perform it. Many hospitals, they don't perform this. And what is your take on it? And then once you complete, I request Murli Mohan sir to how to can you please brief on right heart catheterization and also what is a positive vasodilator test on this, sir? Over to Dr. Shilpa.
To be very truthful, sir, it's now my 15 years practice, and I have never seen a single case of right heart catheterization done in the hospital. So I did my post graduation from Lilavati, and even at Criticare, we have never done a right heart catheterization for measuring the right cardiac size pressures and the pulmonary arterial pressures. Definitely, it's the most invasive test, but and the most diagnostic test for the pulmonary artery hypertension. But surprisingly, it has not been actively practiced. So there, I had a question with Dr. Murali sir for the same. That since we are doing 2D echo in and out for all the patients to diagnose it, is this the main diagnostic modality, or should we practice more of an invasive mode? As you said, that it is easy, cheaper, less invasive for 2D echos, and RHC is very, very invasive. So, should because already PAH is a very, very fatal disease. So, shouldn't we do a more specific diagnostic modality whenever we are suspecting or we have diagnosed to give an exact assessment as what is the pulmonary artery pressures per se? Because 2D echo, as you said, there are a lot of lacuna while doing a 2D echo, maybe the body size, the obesity, the windows, everything. And right heart catheterization is more specific. So shouldn't we do it more often?
Very good points, Dr. Shilpa. I think the important thing to remember is that if it's difficult to do an echocardiogram in an obese person, believe me, it's difficult to do a right heart cath also in an obese person. So it's not the easiest thing in the world. Okay. Second is right heart catheterization carries a very definite morbidity and mortality. You can lose a patient, and then that is why very often cardiologists were very concerned about doing right heart caths because they felt that I don't get that much information about it, from it, and there is a certain risk. Why should I do it? Of course, the cynics would say that there's no money in it and they would rather put in two stents in tandem or maybe do a valvotomy because that earns them more money. But I think that's not true. I think there is a very definite risk. So if you look at right heart cath and you look at the recommendations from the experts, the European Society of Cardiology most recently says in group 1, you have to do it. That is when you have idiopathic, because it's so important, A, to confirm the diagnosis, B, to rule out conditions like group 2 pulmonary hypertension, which we discussed by looking at the pulmonary capillary wedge pressure and so on. Mm-hmm. Recently, we had a patient. I've been treating her now for a couple of years because I trusted an echo done outside to think that it was idiopathic pulmonary hypertension. So she was doing well, but she remained absolutely stable. Then we wanted to enter her into a trial, which is incidentally one of the good reasons for doing a right heart cath. And in the right heart cath there, we picked up the probability that it has a much larger left to right shunt than was determined on the echocardiogram. So the echo, they said, there's only a PF or a patent foramen ovale, small shunt, will not cause this amount of pulmonary hypertension. When we did the right heart cath, we were able to see that there was a significant step up, meaning that there is a very significant shunt. And therefore, the probability is that the pulmonary hypertension is secondary to the shunt, and therefore it is left heart disease, which immediately improves the prognosis. So when you do it, I think it's very important to do it when you have any kind of doubts before entering a patient into a trial. Do it in all patients with a shunt lesion, suspected shunt lesion. So, for example, you've done the echocardiogram, and incidentally, this is another thing I would suggest. Talk to your cardiologist and get what is called a bubble contrast echo or an agitated saline contrast echo to make sure that there are no shunts, either intracardiac or extracardiac. And when you see a shunt, it's very important that you do a right heart cath to quantify the shunt and see if surgical correction is needed, or we continue with medical management. Obviously, the other group in whom we do it is when an organ transplant, like a lung transplant or a heart transplant or a heart-lung transplant is considered. And if you suspect that there's a combination of 3 or 4 different problems, then you do it. We also are doing it in all patients, and this is recommended. In all patients with chronic thromboembolic pulmonary hypertension, you have to confirm the diagnosis and support treatment decisions. In those groups, there is good class 1 recommendations with a reasonably good level of evidence that right heart cath should be done. But remember, you cannot do it very frequently. It's expensive. And as I said earlier, it has a certain risk. So my feeling is that the decision to do a right heart cath should be taken very cautiously, and you cannot override the cardiologist who's going to do it finally. So take the decision in association with them.
Sir, do you agree that we need to do it in more often in our cases? Yes, sir. Thank you. And this question to Dr. Supreet Batra is, so what is the role of diuretics and pulmonary hypertension due to COPD? That's one thing. And meanwhile, please explain the various signs of pulmonary hypertension in chest X-ray. Supreet bhai.
Okay. So we all know that usually the right heart is involved. So whenever, what are the signs which is in X-ray is usually the X-ray is not abnormal, is usually abnormal in patient with pulmonary hypertension. They have a right side enlarged, right atrium ventricle. The pulmonary artery is enlarged. Usually say the diameter is more than 16 to 18 mm. So that is, and there is pruning of peripheral vessels. So these are signs of pH on an X-ray. But X-ray is very useful because it also picks up the other diseases. You can pick up the pulmonary diseases as well as the cardiac disease. So there were a few cardiac signs, signs of left atrium ventricular hypertrophy. You can see the Curley B lines. You can see the pleural bilateral effusion or perihilar opacities, which may suggest that a patient has got an associated left heart disease. And sometimes we know lung diseases can also cause pulmonary hypertension. So patient hyperlucency, or you can see emphysema or hyperinflation in patients. So that may suggest that patient has got underlying COPD, or if a patient has reduced lung volume or fibrotic disease, fibrotic lung disease, or reticular opacities. So that may also point that the patient has got underlying restrictive lung disease or interstitial lung disease. So which are the which may completely change the diagnosis, and the patient may be reclassified into group 2 or group 3. Then coming to diuretics, diuretics are usually done in a patient with heart failure, usually in an acute crisis, and patient has got cor pulmonale and has got a backward failure, like ascites, hepatomegaly, pedal edema. So in those situations, we usually, when there's a fluid overload, we use diuretics, but it is not routinely used because we have got a pH specific drugs. Then in patients, if we have a heart failure, right heart failure only, we are using the diuretics. But remember, we must rule out the other causes of pulmonary artery hypertension. We must rule out left heart disease also, because this may not work in all the patients.
Yeah, diuretics may not be the only solution, and they are indicated when there is a fluid overload state. Sir, any comments from you, sir? Murali, sir.
No, I think that was excellent. I don't think I need to add anything at all.
Thank you. Dr. Ravi, please throw some light on a question there is asking is, what they are asking is, what is Ortner's syndrome? Unmute yourself, please.
Sorry. Yeah, sir, Ortner's syndrome is basically when because of the pulmonary hypertension, there is the trapping of the left recurrent laryngeal nerve in between the aorta and the dilated left pulmonary artery. So because of this, a hoarseness of voice develops. This is a rare symptom of pulmonary arterial hypertension, and it is also considered to be one of the signs of right heart failure. So although a rare presentation, but it can be used for clinically picking up pulmonary hypertension.
Thank you. Generally, we do see in cardiac causes, right?
Yes,
in
cardiac causes
kind of thing. And there is some reports saying that even chronic thromboembolic pH can also results in Ortner's syndrome.
Ortner's syndrome.
Dr. Naeem, what are the various physical signs that you see in a patient when there is a moderate to severe PAH?
Sir, coming to the signs of moderate to severe PH, we will mainly first on the examination, what we hear on the auscultation is a hyperdynamic RV impulse, is what we hear. Then there will be a loud P2 and a splitting of S2 sound. This is what we use to study in our MBBS classes also, and in our post graduation, a loud P2, a splitting of S2, and a hyperdynamic RV impulse. So these things, the basic things will not change. So what I next learned is tricuspid insufficiency and a pulmonary insufficiency, which was something new to me. Over a course of a period of time, I learned pulmonary and tricuspid insufficiency. And there was another thing, I think, venous distension is one more sign which points us towards a pulmonary hypertension of moderate to severe degree. These are the few signs which we can note about, list about.
Yeah, in addition to it, definitely there may be some
orthopnea and clapping,
pedal edema, when there is a
yes, sir.
Okay, in overt failure, okay, you may come across those signs, but I really appreciate. So what our young doctors, they must practice is they must start appreciating loud P2 and right ventricular heave. We must at least appreciate clinically so that we can diagnose. Pardon?
The parasternal heave, the right ventricular heave.
Right. So we must appreciate so that the clinical skills remains the very, very important tools in evaluating our PH patients. May I now ask Jayaraman's question to Dr. Supreet. When do you consider the evaluation of PH in management of OSA and how to manage such pulmonary hypertension? Supreet bhai.
Okay. So we know that pulmonary hypertension occurs in patients with pulmonary disease. So the most common disease associated are COPD, interstitial lung disease, and CPFE, and alveolar hypoventilation. So per se, OSA does not cause pulmonary hypertension unless and until it is associated with some conditions like COPD or there is alveolar hyperventilation. So if there is a alveolar hypoventilation, how to identify these patients? If the patient has got awake PCO2 is more than 45 on an ABG, or if there's a cannot do an ABG, the serum bicarbonate is more than 27. So that suggests that patient has got respiratory acidosis with compensated metabolic alkalosis. So which might suggest that patient has got alveolar hypoventilation, and these are the things in which patient with OSA should have if the patient is having. Other things, we should also rule out other causes of alveolar hypoventilation like hypothyroidism. Patient has got some restrictive lung disease like chest wall disease or neuromuscular diseases or interstitial lung diseases or any chronic hypoxic state. All these can cause hypoxia or hypoventilation in patient with sleep apnea and can lead to pulmonary hypertension. So pulmonary hypertension alone per se will not happen in OSA unless it is associated with hypoxia or hypoventilation state. Then coming to how to manage, we have to identify, we have to do sleep study and can put an end-tidal CO2 in the night and of the polysomnography to see whether it is a sleep-linked hypoventilation or it's a chronic hypoventilation. So if there's that condition is there, then patient should be treated according to the condition like PAP therapy. And if may require, there is a chronic desaturation or hypoxia in the night, then patient should be supplemented with oxygen along with the PAP therapy in the night time. And if it is chronic hypoxemic throughout the day, then he has to use oxygen during the daytime. So basically, it's a combination of hypoxia, chronic hypoventilation, which are associated with the OSA, which leads to pulmonary hypertension.
Thank you, Supreet bhai, for a wonderful explanation. Over to Dr. Murali sir. Sir, Dr. Jayaraman was specifically asking you, is there any oral antihypertensives that can be used in such case of OSA for management of pulmonary hypertension? And when to refer such patients to, when will we refer pulmonary hypertension patient to lung or heart-lung transplantation in presence of severe pulmonary hypertension?
Dr. Jayaraman is working in one of the best centers for lung transplant, but basically we also do lung transplants. And in lung transplant, there are two stages. The first is the referral, and the second is the listing. So when do you refer a patient for assessment for lung transplant is when they have progressive disease. You've been treating them, but they've been progressing. And despite all your treatment, you find that, the person needs to come into hospital. So at any time a person is hospitalized for pulmonary hypertension, you need to consider doing a lung transplant. The second is when you're considering prostacyclin therapy. So you have them on, the PDE4 5 inhibitors, you put them on the endothelin antagonist oral treatments, and still they're not working. You're now considering prostacyclins. Generally, we don't include patients on selexipag, which is also a prostacyclin analog. But once you consider them for prostacyclin therapy, refer. The third is when there are some odd features and you suspect this person may have, something like PVOD, PCH, those rare conditions that I spoke about. If there's an associated large pulmonary artery aneurysm, which may be due to the pulmonary hypertension, person is probably going to benefit also. And when there are other organs getting affected because of the pulmonary hypertension, for example, a person is going to a cardiorenal syndrome, it's a good idea before his kidneys get knocked out to refer him for a lung transplant. The next stage is when you actually list the patient. And you list the patient when you've completed the first stage, you've gone through the pulmonary rehabilitation and everything. The second is when, despite your treatment, the person's risk score, and we'll come back to risk scores later, I think, the risk score, for example, the Ravi risk score is very high. You put him on all the treatment. The goal is to get the person to go from a high risk to an intermediate to low risk, but the person remains adamantly in a high risk in spite of all your treatment, then refer, because the person is not responding and they can go acutely into failure and die. The third is that the patient is getting more and more hypoxic. And finally, as I said, definitely if the other organs start getting into problems, you may have to start listing this patient. So that is the referral and the listing steps for lung transplantation, which based on the team's decision will be only a lung transplant, because the right heart recovers beautifully. But if you have a combination of right heart disease, left heart disease, and lung disease, then very often they'll do a heart-lung transplant, which technically is easier than doing a lung transplant alone. That was the first part. The second part, sorry, Dr. Vijay Kumar, I've forgotten what the...
Antihypertensives, any antihypertensives that can be used for in management of pulmonary hypertension.
So group 3 pulmonary hypertension, generally, it's not a good idea to use any of the pulmonary vasoactive medications. And I think that's very important to remember, because there is definite evidence. There was this very good trial called, which was reported, the VA trial, where they looked at all patients with group 2 and group 3 PH who received and who did not receive pulmonary vasoactive medication. And they found an almost 36% increase in the mortality rate for patients with heart disease and lung disease who are receiving pulmonary vasoactive medication. So oral medications definitely not to be used, at least according to current knowledge. The new ones may come out. I think Dr. Naeem already spoke about the serotonin-related group of drugs, which, the antagonists, which may play a role in the future. But right now, that is not recommended for group 2 or group 3. But there was a very interesting trial recently, the INCREASE trial, published about 2 years ago, if I remember right, Waxman and colleagues, where they used treprostinil, inhaled treprostinil in patients with IPF. And they showed that these patients actually had better outcomes as measured by pulmonary pressures and as measured by the 6-minute walk distance. So when you use inhaled medication, perhaps it will be beneficial. Oral medication, at this point of time, we will say don't use it, irrespective of the cause of pulmonary hypertension in group 2 and group 3.
So without wasting much time here, thank you, sir. And over to Dr. Shilpa. Sir has brought in wonderful assessment tool and monitoring tool, 6-minute walk test. How do you pursue? How do you see that? How much clinically it will be useful, the 6-minute walk test, in assessing the pulmonary hypertension patients?
As we all know, that 6-minute walk distance is a most cheap, inexpensive tool, requires very less space. And pulmonary artery hypertension patients usually have a lot of exercise intolerance. So 6-minute walk distance as well as cardiopulmonary exercise testing is a very good prognostic marker, as well as it helps in gauging what will be the improvement with the medicines which the patient is going to take eventually. Um, it has been said in various studies that a 6 minute walk distance of more than around 400 meters is a very good marker for having a very good survival index for a patient with pulmonary artery hypertension. But however, you cannot generalize it, for the reason is we don't know. We cannot gauge that whether it is being generalized to a mild, moderate, or severe PAH. But still, it is being a very inexpensive tool. So usually into the OPD basis, patients are being subjected to a 6 minutes walk distance because it can be easily done and you can definitely gauge. And it is a very nice way of understanding that patient is improving or deteriorating over the period of time with the distance covered. If the distance is reducing, then definitely the patient is eventually progressing and the risk of mortality is going a little bit higher. As I said, that you cannot generalize it because we still, it has not been into a large scale that a mild pulmonary artery hypertension patient, just mere on 6 minute walk test, is going to survive for a longer duration of time. As we always keep saying that there has to be other comorbid factors, like the patient is having a lung condition add on or a cardiac condition. So looking at the whole scenario, it is not the only tool, but a very good inexpensive tool to go about for gauging the prognosis as well as the response to the therapy.
That's wonderful, Dr. Shilpa. So, Murali sir, again coming back to you, there is a question which asks, see, how do you determine the risk of pulmonary artery hypertension according to 2015 ERS ESC combined guidelines, basing on the 6 minute walk test, presence of symptoms like syncope, and NT-proBNP?
So, I mean, that's a very good question because it's really the most important part when you're trying to put a patient with pulmonary arterial hypertension on treatment. So you first do a risk assessment, and there are several risk scores. The REVEAL score is the one that we use most often. It's a little more demanding. So basically, do you think I can share my screen now?
Yes, sir.
Dr. Vijay Kumar? So because it's easier if I share my screen and show the REVEAL score. So this is the REVEAL score that we use. And as you can see, sorry.
That's visible, sir.
It's visible. No, I'm just trying to put it into play mode.
Yes, sir.
Yeah. So we divide patients into 3 risk groups: low risk, intermediate risk, and high risk. So these are some of the things that Dr. Vijay Kumar already told you about. Are there clinical signs of heart failure? Are the symptoms progressing? Is there a syncope? What is the functional class? What is the 6 minute walk distance? As Dr. Shilpa just said, about 440 meters is very good. If it is less than 165 meters, it's very bad prognosis. You do a CPET, you do the NT-proBNP levels, you look at the imaging and you look at the RA size and the hemodynamics, which requires a right heart cath. And based on this, you decide is the person low risk, intermediate, or high risk. But what I use these days, because, this one demands hemodynamics and imaging and so on, what I'd use is usually the REVEAL Lite 2 risk calculator. This, by the way, is available on the net. You just put REVEAL Lite 2, you'll get this risk calculator. So this uses the BNP or NT-proBNP, the 6 minute walk test. You ask the patient for the functional class, you measure their BP and heart rate, and the only blood tests you need to do are the serum creatinine, on which you base the EGFR, and the BNP. So based on this, you can put the patient into, add up these, and you put the patient into the total risk based on the low risk, less than 5 or equal to 5, high risk, 8 or more than 8, and in between 6 and 7, you have the intermediate risk. So based on these, you do your treatment plan, aiming for certain targets, and if you can get a mean pulmonary artery pressure less than 42.5, look at the survival. The 15-year survival is almost 100%. If it is more than 42.5, you don't get that good, though it's still very good. You get survivals, 50% survivals of, median survivals of more than 10 to 12 years. But if the lower you get the mean pulmonary artery pressure without causing side effects, the better are your outcomes. So that is, how you use the risk scores. And as I said, the REVEAL 2 Lite score is available on the net. So please use it when you're looking after your patients.
Thank you, sir. That's wonderfully summarized. Dr. Ravi, when is a combination pharmacotherapy considered in pulmonary hypertension?
Well, I would like to reverse engineer this question, sir. Now, combination therapy is the most recommended therapy for pulmonary hypertension. So it is only not recommended when suppose you have a actual vasoreactive pulmonary hypertension where you have done a right heart catheterization and they are sensitive to calcium channel blockers, or if you have already existing patients who are stable on monotherapy, then only they are to be continued. But if now on you are diagnosing any newer patient with pulmonary hypertension, then ideally, if they fall in the intermediate or high risk group, based on either the reveal score or on other pH assessment scores, if it is intermediate to high risk, ideally we should prescribe combination therapy. The first idea of combination therapy came from the PACES study, in which sildenafil was added to existing therapy, and they found a decrease in mortality and improved symptomatology. And even the 6-minute walk test started improving. Followed by that, there are several notable trials, most importantly being the AMBITION study, in which ambrisentan was studied. And then there are several studies which are more recent, like the Athena 1 for ambrisentan and Patent 1 study for Radiology. But most important thing is we should try to avoid using combination therapy of agents who are having similar mechanism of action. For example, if you use sildenafil and Radiology together, then that is not proper since they have similar mechanism of action. So combination of therapy with two drugs having different mechanism of action in intermediate and high risk group patients is indicated.
So here, Doctor, again this question to Dr. Ravi Dosi. Dr. Sakshi from Telangana, Hyderabad is asking, good evening, sir. It's a wonderful webinar going on, very informative. Here I wanted to ask regarding management of pulmonary hypertension in COPD cases. Is it just treating the cause, or is there any role of PH medications? That is sildenafil, tadalafil. So what is your comments?
Again, if you look at the official recommendation, what the guideline says, they say that in patients with lung disease and severe pulmonary hypertension, an individualized approach to treatment is recommended. This is level 1 recommendation. It neither says no, neither says yes. You have to optimize your lung therapy. Followed by that, you have to go ahead and see what suits the patient and treat accordingly. And if patient is having end-stage lung disease, then lung transplantation, referral and listing has to be done. As far as the pulmonary arterial hypertension medication is concerned, I feel that if the patient is having right heart failure, then along with diuretics, digitalis, maybe you can go ahead and try any pulmonary vasodilator.
Right.
But
So,
sir, isn't it said that by using vasodilators, just wanted to know that in COPD patients, isn't it said that by using vasodilators, it causes increase in the shunting? Due to which we usually don't prefer using vasodilators.
Yeah.
I mean, Dr. Dosi or Dr. Murali, if you can comment that.
Yeah, maybe I think we should have a word from Murali sir in this. What is the final word?
Okay, before I go, I think Dr. Krishna wants us to announce that there are 1,055 logins live right now. So that's amazing. We have a great audience. This is the strength of CCI. So wonderful. So going back to your question, Dr. Shilpa, I quite agree with you that, as I mentioned earlier, there's good evidence that you should not use these because it increases shunting. The exception being when you have either a significant out of proportion pulmonary hypertension, which assumes that there's a significant element of group 1 pH. If I can dial back a little, when you have pulmonary hypertension, going back to what we learned from what Dr. Naeem told us earlier, when you use the anorectic agents, the dietary, the things which are supposed to reduce weight, they learned that people who have a genetic predisposition and who receive these are the ones who develop pulmonary hypertension. It's not enough just to take those dietary agents. What you have to have is a genetic predisposition. So we now talk about a 2-hit hypothesis, or more likely what is called a multiple hit hypothesis.
Multiple hit hypothesis.
Yeah. So you start with a genetic predisposition, but there has to be one or more environmental factors. So one of the environmental factors may be the hypoxia, that is the lung disease. Okay, so if a person has a genetic predisposition and a lung disease, they are much more likely to develop not just group 3, but also a group 1 pulmonary hypertension. So these patients will benefit. How do you recognize these patients? You look for disproportionate pulmonary hypertension. This is what both you and Dr. Naeem brought out. The FVC is very good, greater than 70%, whether when you're dealing with the case of ILD. The FVC is greater than 60%. If you look at the FEV1 in a patient with COPD, it is greater than 60%. If you look at the oxygen, there's no hypoxia. Look for nocturnal hypoxia in such patients. And I think Dr. Supreet brought out beautifully the role that, sleep apnea plays. And sleep apnea does nighttime hypoxia. If you take patients with OSA, OHS, again, Dr. Jayaraman's question, again, these are the patients who will probably have predominantly group 3, but could have a significant element of group 2. And if both the heart and the lungs are normal and the pressure is disproportionately high, then you start doing it. One of the other things to do is to do a CPET. If you do a CPET and you find the person has a very diminished vascular reserve, I'm not going to go into CPET. We should probably get somebody like Dr. Deepak Talwar to do it for us because he is the expert in, CPET. If you find a diminished vascular reserve, you're probably dealing with group 1. If you find a diminished ventilatory reserve, that means you start doing the exercise, the oxygen starts dropping and the CO2 starts going up, then you're probably dealing with somebody with a reduced respiratory reserve. Those are patients, there's no point in using pulmonary vasoactive medication.
Thank you, sir. Thank you so much.
Thank you so much.
And here comes the question to Dr. Naeem. So, is there any role of pulmonary artery denervation in pulmonary hypertension? What is the evidence says?
So honestly speaking, this was new to me also, and I went through the literature, and what I found is pulmonary artery denervation, it mainly acts by blocking the sympathetic activity, limiting the sympathetic activity. What they do in this procedure is a catheter guided ablation, where they target the efferent and the efferent fibers of a baroreceptor complex, which are usually situated in the pulmonary artery trunk and its bifurcation. This is the area where they hit through the catheter, and by limiting the sympathetic activity, they try to control the pulmonary hypertension. This main group of patients which have been selected for this type of intervention where the pulmonary hypertension which were having the left heart disease, who were having the high mortality. In these patients, they have found some improvement in the hemodynamics and exercise tolerance, but yet the mortality rates have not been commented, as it is not a routinely practiced procedure.
Yeah. Thank you, Naeem Bhai. On the other hand, I just want to bring a holistic approach to this question. As they try to denerve the sympathetic system, there is another way or yogic practices. They say activation of vagal nerve system. Okay, vagal system, parasympathetic system can be activated by various exercises that is there, and then please meet the expert physiotherapist and then suggest them to do vagal nerve activation. That is a easier way to perform than sympathetic denervation. Coming to Dr. Supreet.
Can I just add for that, Dr. Vijay Kumar?
Yeah.
You'll have to do this early, because once the pulmonary vasoconstriction, this is the stage of pulmonary vasoconstriction. Once the vasoproliferation and the smooth muscle hypertrophy occurs, you're not likely to achieve very much. Yes, so if you're going to do it early. But there are some interesting studies. So.
Yes, sir. In Telugu, there is a saying, sir, if you permit me. So, Mokkai vanganidi manai vanguna. Beat the iron when it is really hot and get a shape to it. Otherwise, it is very impossible to manage pH. And coming to Supreet Bhai, what are the various ECG signs that we need to see as a beginners and then as an experts? And what is the significance of RS ratio in V1 lead?
So as we all know, in pulmonary hypertension, the right heart is affected. So we know the common findings are is a cor pulmonale. We usually have a P pulmonale, which indicates right atrial enlargement. There can be right ventricular enlargement also, which can be seen on ECG leads. There's a RS ratio, R may be in V1 or S may be in V5 or V6. It's more than one. Then there will be right axis deviation. And there can be another thing is right ventricular hypertrophy. All these are findings can be seen in patients with pulmonary hypertension. And when the disease get really advanced, there will be RV strain pattern. RV strain pattern, there will be ST segment depression or T wave inversion, precordial leads and inferior leads. And sometimes we got when there's a hypertrophy also, there's a decreased depolarization and leads to QTC prolongation. So that QTC prolongation and RV strain pattern, these are seen in advanced diseases. So if the patient are really advanced, we can see these patterns in patient with ECG. And they have a poor prognostic and independent risk of mortality, the predictors of mortality.
Thank you, Dr. Supreet. And can you please summarize, Ravi bhai, why VQ scans are better than CTPA in assessing Group 4 PAH patients, particularly CTEP?
The sensitivity of VQ scans is as high as 97% as compared to 50% for CT for this CT pulmonary angiogram for CTEP, sir. And the specificity is 90% as compared to 99% for CTPA. Apart from that, there are some additional advantages like there is a lower radiation exposure. The IV contrast complications are much less with VQ scan, and the efficiency is more with the VQ scans. But the only problem is that they are not very specific for CTPH. You can use them, but not very high. They can give false positivity in fibrosing mediastinitis or pulmonary artery sarcoma-like cases. So overall, it is better, but the technical limitations are also there with VQ scans.
Thank you, Dr. Ravi. Dr. Naeem, in patients with HIV...
I'm really sorry, Dr. Vijay Kumar, but I must intervene. I think all this is based on an old study, TAPSON study, which came a long time ago. The quality of CT pulmonary angiogram has improved hugely. And I think they are comparable in terms of, their performance, both sensitivity and specificity. Where I think the problem comes with CTPA is sometimes it's too sensitive and it may pick up clots which may not have too much clinical relevance. So the problem is not lack of sensitivity. Previously, it was thought to be 50%, but now with the high resolution stuff that we get, you're able to pick up very, very effectively, do it perfectly, locate the arteries, which is very important when you're planning surgery. So honestly, we use VQ as a backup, and our main go-to is CTPA. As Dr. Ravi Dosi said, you can get CTPA done virtually every place. It's very difficult to get VQ scans. So I think long and short is please use VQ scans secondarily, but use CTPA first.
Thank you, sir. Dr. Naeem, in patients with suffering from HIV-associated pulmonary arterial hypertension, and when do you see at what level of CD4 count below which the prognosis become very bad? And do you think thus direct infection of pulmonary vascular endothelial cells leads to the pathogenesis here in PAH? What is your take in HIV patients?
So see, when you talk of HIV patients, HIV-related PH, I think we come in group 1, and it's a very rare complication. It's around 0.2 to 0.5% is the percentage which has been found in which HIV-related pulmonary hypertension we are noticing. So what actually happens in HIV patients, there is already an immune dysregulation. There is a chronic inflammation going on, which in turn causes an increased cytokine release and a TGF related that promotes PH. So the combined pathogenetic factors work together here in causing a pulmonary hypertension. So coming to our question, what is the CD4 count where we can think of pulmonary hypertension? It has been found in 2 studies. That one study found that a CD4 count ranging from 300 to 400 is the range where we can have a pulmonary hypertension on an average baseline.
Thank you, Dr. Naeem. And Sir Murali sir, again, a very interesting practical question. So what is the role of digital is? So when I was a student 25 years back, I have seen prescriptions mostly the digitalis was used left and right, both in right heart failure, left heart failure, whatever it is. Patient have AF, they use. And I want to listen from you, and then please enlighten our 1,000+ audience, sir.
So I'd agree with you. I don't think there's a role. We used to use it a lot because there was a complete lack of drugs. Now I don't think there's any role. I always teach that there is only one role for digitalis in, medical practice. And that is when you want to control atrial fibrillation with a fast ventricular rate. And you're looking only for rate control. You're not looking for rhythm control.
Right.
There is, however, a couple of exceptions. When you're looking at diuretics and you're looking at digoxin, when a person has very severe right heart failure, a lot of edema, the chest wall is full of fluid, the abdomen is full of fluid, then using these, because then breathing becomes very difficult because of the inertia of the chest wall and abdomen, then maybe it is permissible to use diuretics and digoxin. But otherwise, they really don't have any role. I would think it's no evidence in its favor.
Almost obsolete.
Almost absolute, absolutely.
Right. And Supreet Bhai, please throw some your experience of how PAH and schistosomias are associated. Have you come across any case so far?
No, I have not come across any case, but I have just learned from the pathophysiology that it comes in group 1 pulmonary hypertension, and usually it is basically the host response to the eggs. So it is commonly seen in hepatosplenic schistosomiasis disease, where the cystosome eggs, they occupy the pre-sinusoidal portal pre-sinusoidal spaces, where there's an inflammation and fibrosis and leading to portal hypertension. And then there is a opening of collateral vessels, and these eggs get embolized to the lungs. And again, in the lungs, they get trapped in the arterioles, and where there's a host response, inflammation and fibrosis leading to pulmonary hypertension. So this is a basic pathophysiology in case of schistosomiasis, and it is mostly common in hepatosplenic, where there's an opening of shunts and collaterals.
How do you manage this, Bhai?
So management is only if it is early in the disease, it is basically the management of schistosomiasis. The disease only is the management in the early part of the infection. But if it's a chronic disease and hypertension, then you have to treat the patient according to the status and give the PAH drugs along with the schistosomiasis, the basic management, the treatment.
Thank you, Supreet Bhai. So it's time 9:49. We'll try to wind up. Yes, there is a lot more to discuss. So even if 1 more hour is there, we may not able to complete. And then there are plenty of questions that is pouring in. But in the last, I presume last 6 minutes, okay, what we can do is, so I ask from the expert, national expert, about the indications of pulmonary thromboendarterectomy. I'm sure sir is at his institute. Okay, he has a vast experience. I think they're the best of the best in entire India. Sir, please throw some light on this, sir. What are the take-home points here on thromboendarterectomy?
So the first and most important thing to remember is that whenever there is chronic thromboembolic pulmonary hypertension, the ideal treatment is pulmonary endarterectomy. So you can call it thromboendarterectomy. The important thing is it's not just removing the clot, it's removing a layer of the endoarterium or the endothelium along with it. And lifelong anticoagulation is needed. So as long as there is pulmonary hypertension and the patient can tolerate the procedure, it is the treatment of choice. If the patient has disease which is in the larger arteries, that is the main pulmonary artery, the branch pulmonary arteries and the lobar arteries, and even the segmental arteries, pulmonary endarterectomy is indicated. If it is in the subsegmental arteries only, and that is sometimes a problem, and the smaller vessels, then perhaps we move to balloon pulmonary angioplasty. And we are doing quite a few of that, and that helps because there's good evidence from Japan that it is a very effective procedure. Japan, apparently, culturally, they don't like to have their chest cut open, which has to be done for an endarterectomy. So they devised, and they've done very well with balloon pulmonary angioplasty. The symptoms improve, the functional class improves, but actually the pressures don't drop as much as with the pulmonary endarterectomy. So I think the first thing you need to do is establish, does this person have chronic thromboembolic pulmonary hypertension? Second, make sure that the patient is operable and will tolerate the surgery. Sometimes a person who has, in fact, today we turned down one patient because we thought he had mainly small vessel disease. So these patients, when they have very severe small vessel disease and not so much central disease, and you do the surgery, you can actually end up with reperfusion pulmonary edema because you open the central clots and suddenly flood the distant areas. So those patients you may not take up and you just manage them medically. But I think almost 4 in 5 patients who come with a referral, we take up for surgery. The third thing that one needs to rule out is when it is not clots, but maybe tumor emboli, for example.
Right.
We had one patient we operated on for Echinococcus multilocularis sitting in the pulmonary arteries. And that patient did very bad. So you have to be sure that you're dealing with clot, not with tumor, not with parasite. And you have to make sure that it is not too much of small vessel vasculopathy, which will not improve.
Thank you, sir. So, but I was told that because we had experience of almost 3 patients in Hyderabad, not our center. So, 2 of them, they died during the procedure and or immediately after the procedure. One survived for almost 3 months or 4 months only, sir. What is your take on mortality of such a procedure of thromboendarterectomy?
A very good question, because it is a very demanding procedure. There's a very, very steep learning curve. So when you start, mortality rates are high. In our center, I think it was 14.5% mortality for the first 50 cases. After that, it's come down. Right now, it's running at about 4%. The best centers in the world do it at about 1.5 to 2% mortality. That is including, to discharge. So 98% plus make it out of hospital. If you choose your cases correctly, you will have a very good outcome. But yes, in the beginning, if they've done 3 or 4 cases, they expect higher mortalities, but it's part of the learning curve. It's very unfortunate for the patients, yes, which is why also ideally your patient should be referred to a center with expertise, because their results are bound to be better. And you made a very important statement. It was not during surgery very often that the mortality occurs. It is post-op in the first few days, which is why it's not just the surgical skill. It is the ICU skill, the post-op ITU, who play a key role in keeping these patients alive and taking them out of hospital.
So, my dear pulmonologists, please understand, pulmonary thromboendarterectomy is not like doing a bronchoscopy or ICD or like a lobectomy at the max. It is altogether different league. We need to refer to the patient to the centers where the turnover of these cases are really high. I have a patient, Dr. Shilpa. Okay, she is around 24 years young. She has severe pulmonary arterial hypertension, idiopathic, and she wants to listen from you. Okay, do you want her to get married? First question. Second question is, if she gets married, she wants to have conceive as well. What is your take?
Usually in pulmonary artery hypertension, that is idiopathic pulmonary artery hypertension, it is not recommended to be
severe,
pregnant.
not too severe.
Severe. It is not recommended because we have to first counsel them that there is a very high risk of, she can definitely get married, but definitely she should not go into the whole set of pregnancy because there is high risk of mortality both to the mother as well as to the fetus. As we know that it is almost 15, 35, 50% in females who are pregnant, and in fetal death is almost 15 to 20%. Along with it, the most commonest cause of all these things is right heart failure, stroke, very heavy postpartum bleeding. In female, they have a mortality because of that reason. And in children, the fetus, usually it in the form of a IUGR or maybe in the form of intrauterine death itself. We have to first counsel them properly that don't go into the fact of going into pregnancy. Some people still force into going into pregnancy. So you have to give them a proper counseling session in the sense of what are the complications which they can have, the whole thing which can have a proper session with the doctor, a proper pediatrician who has to take care of the fetus altogether throughout the entire risk of pregnancy, the time which the patient is going to go for. Any which way is the person who is in severe PAH is a refrain completely from pregnancy altogether. But still, there are some patients who still want to take that risk, highest point of risk.
So even if they are willing to take risk, we are not supposed to encourage.
We should
That is
not.
the
We
point.
should not.
And question to, before wrapping up, question to Dr. Naeem. Yes, what is a subcutaneous prostanoid therapy? Is it available in India? Unmute yourself, please.
So coming to the prostanoid therapy, vasodilators, as the name in itself says, they vasodilate. So I would just go beyond my question. It started with epoprostenol, which was an IV form uh, to deal with the pulmonary artery hypertension patients, and it had promising results. And what was bothering while using epoprostenol IV was the chronic indwelling catheter use. Second issue with this was the reconstitution of the drug, and third thing with this was the operation of the infusion pumps. And all these three factors led to the easier mode of delivery system, and came into the being what we call as subcutaneous prostaglandin therapy, what trepoprostenol, and which comes with the brand name of remodelin. It is given subcutaneously, and its half life is an issue which ranges about 2.5 to 3 hours. And the good effect of this is it improves the exercise ability, it improves the hemodynamics and the shortness of breath. Then another invention in this segment came, as Dr. Murali sir said, the inhaled prostacyclins, the iloprost, which was more selective, and it has then selective effect on the hemodynamics and the lung vasculature, thus avoiding the systemic side effects which were caused by the IV drugs. So the only segment of these drugs is the half life of the drugs, but they have a promise in the treatment of pulmonary hypertension.
Thank you, Dr. Naeem. It was a wonderful, very lucid explanation. So now every great things come to an end. So there are plenty more questions, but there's not much time. Technical team already alerting me. It's close to 10. They have to have their dinner. So quick one line take home points. Dr. Ravi Dosi, first you.
Hi, Chennamchetty. Namaste.
Krishna sir.
Krishna sir here is here. Wonderful. Wonderful to have Krishna here.
Thank you so much. Wishing everyone a happy Ganpati Visarjana and happy Eid Milad.
Same to you, sir. Same to you, sir.
Thank you very much.
And, you guys did brilliant. We have 1055 logins, as I have already quoted in the group. And this stood amazing because this is a match where I can see Gavaskar is batting with Tendulkar and even with what you call as our
Afridi,
Virat Kohli.
Afridi.
Virat Kohli. No, why you are Afridi? You are not Afridi. How come you become Afridi? There is no Afridi.
You cannot become Afridi.
No Afridi player by in India. We can proudly call you as Siraj.
Azharuddin.
Proudly Siraj and Azharuddin. Why should I call you as Afridi?
Sir, it's okay.
Okay, so guys, it was fantastic. Please go ahead taking the concluding remarks from everyone.
Yes.
And we shall end the call.
Thank you, Anna. Thank you.
Thank you, everyone.
Thank you.
Okay. Bye.
Ravi, bye.
My only simple message is lot of pharma nowadays comes in with a lot of new molecules, new names and new data, but we should be very clear and stick to guideline based management while using combination therapy for PH.
Over to Dr. Naeem.
My take home message to the beginners will be concentrate on the basics while evaluating these patients. And once you find yourself in a dilemma, talk to the cardiologist.
Dr. Shilpa.
My take home message is to hold on a good cardiologist who can do a very right 2D echo And you should definitely take active participation in what the person is doing and what details do you want from the for the patient. It is very important part for diagnosing TAH in India, at least, wherein 2D echo is the most important test for finding it.
Dr. Supreet?
So my take-home message is you should evaluate the patient in as a whole. Do not go in a hurry. And the thing is, these patients should also be given vaccinations. And the last thing, what I have seen is people commonly give medicine, pH medicine in patient with lung diseases, which should be avoided because there is a grade 2B recommendation now, and many cardiologists are using it. But you should not use it because there is no evidence to use it. And please don't do your medicine in patient whenever you see pulmonary hypertension done by echo and it shows PASP this much and how much value. So please concentrate and evaluate the patient properly and identify the etiology of the disease. That will make you a better at managing your patients.
Thank you. And I can say man of the match, man of the series, national man of pulmonary hypertension. Murali sir, your concluding remarks.
Thank you. Dr. Krishna left out Rahul Dravid. You keep calling me Dravid, and I like it because Dravid is my schoolmate. I mean, many years junior to me, but the same school. So, so anyway, small comment. I loved all the comments the others made. I'll just say, try always to have a high suspicion for pH. Make a diagnosis early. As Dr. Supreet Batra said, etiology is a must. Functional classification is a must. And always keep reevaluating your patients with lung disease or other diseases for the possibility of pulmonary hypertension and treat them in combination with your cardiology colleagues.
Thank you, sir. So, here, what is my conclusion statement is, first of all, appreciate Dr. Naeem for bringing this unique concept into CCI's vision to take this pH topic, and then it is one of the most complex topic that I have handled so far in a webinar. Initially, I felt, to be honest, to moderate this session, to moderate Murali sir, I was nervous. Let me admit it.
So even
But having said this, I did my homework. Okay, I read thoroughly, and then I'm here. And please, my dear friends, pH, unless what is visible is, unless your eyes can recognize pH in the given patient, you cannot recognize and then treat this subset. It is not clearly evident. It is the most important disease which is often missed by our cardiology colleagues, and even sometimes we also miss it. So please keep extra focus to identify pH cases and then start early the treatment. That is the most important. Unless you identify, you cannot treat it. So start identifying early, treat it very well. And I want to add one important thing. 2D echo is not a very difficult thing to learn. So spend some time, go for some training, maybe workshops, or spend with your cardiology friends. 1-2 months. That is really good enough. Doing for 25-30 cases is good enough to learn a good 2D echo, particularly right heart parameters. Start learning on your own so that you can measure your own self, so that you can avoid the bias, which is often a big problem, because every time our patient is being seen by different technician, they report differently. So to avoid that, learn echo by yourself, and then very judicious usage of medication, identify the problem, and then correct the pathophysiology. That is most important. Always remember, depend on scientific evidence before you start prescribing. Thank you, CCI core team, Dr. Ashish, Dr. Anil, Dr. Atri, and Narayan Pradeepa, Krishna Anna, our SIPLAs. Huge strength is Vipul, Vinod, Amit, and Bezel. These are all, playing a very wonderful back support to run this CCI webinars for the past 3 years without any break. Thank you so much, one and all. Love you all. CCI comes to you with next wonderful webinar next Thursday evening. Thank you.
My message, final
Before
message.
we go, fantastic
my final
moderation.
message.
Dr. Vijay Kumar, superb, great questions, brought out the whole thing. Truly admirable. And thank you, great panelists here.
My final message, please.
Yes, sir.
Long
Go ahead.
fraternity, long live pulmonology, long live Chest Council of India, long live India. God bless everyone.
Thank you.
Thank you so much. Thank you.
Good health.
Thank you so much.
Good night, everybody.
Good night.